Good evening, everyone. Welcome to today's masterclass, brought to you by the Academic Council of Indian Association of Surgical Oncology. Topic for today is maxillary tumors. I welcome our President, Dr. Rajin Tuprani, to kindly open the session.
Good evening to you all, and welcome to this second session in 2022 for the masterclass activity. At the outset,
ये एक्सरे करने को बोला है, अभी एक्सरे दे.
At the outset, let me welcome our new advisory board committee members, Dr. Harit Chaturvedi, Dr. Sanjay Kapoor from Kolkata, Dr. Hemant Raj from Chennai, and Dr. Sanjay Sharma from Mumbai will be our new advisory board committee members for the IASO academic activity. And today's topic is maxillary tumor. And our moderator for today's meeting is Dr. C.S. Mani. He is a good friend of mine and a senior consultant at Apollo Hospital at Chennai. And he did his MCS from Madras University in 1998. The examiners for today's session would be Dr. Prathamesh Pai. I don't think he needs any introduction to this audience. He's the president of FHNO and he's a consultant at Tata Memorial Hospital and the convener of the skull-based clinic. He was awarded the UICC Fellowship, Secret Fellowship for Germany, training at Germany, and Hargovind Fellowship for at University of Pittsburgh in USA. And he is the founder secretary of the Indian Society of Thyroid Surgeons. He has got a special interest in endoscopic and open skull-based surgery, conservative laryngeal surgery, and transferal laryngeal surgery. The second examiner is young, dynamic, and dashing Dr. Shamit Chopra. He is an HOD and the Department of Head and Neck and Reconstructive Surgery at Patel Hospital, Jalandhar. Chairman of the Oncology Committee of the IMA Punjab, an executive committee member of FHNO, and looking after the fellowship program for the FHNO. He has got many abstracts and publications name. So with this short introduction, I think without wasting time, let us start the program.
Thank you so much, sir. The examinees for today will be Dr. K. Gayatri, who is a resident in the Department of Surgical Oncology at Nizam Institute of Medical Sciences, Hyderabad. And with her, we have Dr. Ram Subba Reddy, who's a resident in the Department of Surgical Oncology at Cancer Institute, Adyar. A few instructions for the session. The first 45 minutes of this would be a mock examination in which our request to the examinee is to kindly give to-the-point answers. No one is ever expected to know everything, so there's no harm in mentioning, and pass it to the other one. It saves us time and maintains the flow of this webinar. And our examiners do have a habit of giving hints. It's up to you to catch it. For our dear examiners and the moderator, in interest of online viewers, both who are present live as well as the future viewers who are viewing it on YouTube, we request you to give the expected answers to the questions that remain unanswered or have been incorrectly answered. For the senior IASO members who are in the participants, we thank you for attending, and we please request you to post in your inputs as well into the chat box. And for the residents, this is a unique opportunity to clear all your doubts. Please make full use of it. I'll be reminding the examiners and moderator at 30 minutes and at the conclusion of case discussion via chat. With that, I request our moderator, Dr. C.S. Mani, to kindly share his screen and take hold of the proceedings. Thank you.
Dr. Mani, you're muted.
Yeah. Can you hear me now?
Yes.
Yes, we can.
The slides are visible now?
Yes, yes, they are.
So who will be the candidate who would first respond, or is there any method like that?
Sir, we'll request you to kindly ask them one by one and make sure that both of them get equal opportunities.
Okay, sure. So this is a case of a 52 years old man who came here with a facial swelling of 6 months duration. So the image is given. So Dr. Gayatri, would you want to go for this?
Hello, sir.
Yeah. Would you like
Yes,
to
sir.
make some comments on this?
Yes, sir. He's an elderly male, like above years of age, and he's complaining of swelling in the left malar region, and also there is proptosis of the eyeball. So I would like to give diagnosis of maxillary tumor, sir.
All right. So what makes you think it's a maxillary tumor just looking at his face?
It's like the main is when an elderly person who is complaining of unilateral facial puffiness, pain in the malar area, in proptosis, we usually give a I would like to give a differential diagnosis, but my first diagnosis is carcinomas, tumors arising from the antral region, sinonasal tracts.
Gayatri, I'm going to interject with the moderator's permission. Dr. Mani, if I may.
Please.
Again, maxillary tumor is a differential, but that being said, you probably with the limited information that moderator sir has given you, you'd probably want to list more differential diagnosis. And of course, we want to also mention certain symptoms and signs which you would want to know. So this is probably a time to question the moderator as to whether the patient had any other symptoms, what signs was he able to elicit, and what investigations you would get. However, if the examiner asks you about your differential diagnosis, then the age-old axiom of infectious, inflammatory, traumatic, and neoplastic should come into mind, and you should be broad-based in your answer currently, as opposed to just calling it a maxillary tumor.
Yes.
Ram Subbareddy,
Sir.
what are the other symptoms you would want to know from this patient? You know, he just mentioned there is a swelling, but what other specific symptoms would you want to ask for, and what the clinical signs you look for in this patient?
Any associated with fever and then pain, any loss of sensation, any loss of vision.
So you have to be specific to say which region the loss of sensation and why you are asking for the loss of sensation. The explanation for that as well.
When it is involves the infraorbital nerve, it will cause the paresthesia or hypoesthesia.
All right. What else will you ask for? Dr. Gayatri, you want to fill in?
Sir, whether he is having any discharge through the nasal discharge.
Yeah, right. So nasal discharge is something. Nasal. Yes. What else?
Whether he is having any signs of trismus, difficulty in swallowing.
Why trismus?
Some tumors, some inflammatory conditions, or it can involve the temporomandibular joints.
Inflammatory conditions and involvement of temporomandibular joint. Temporomandibular joint is involved by what?
Inflammatory conditions can cause joint pains at the TMJ joint.
Oh, I see. Okay. The examiners want to add in something here, please.
Subbareddy was on the right track. Maybe we need to ask all kinds of symptoms in the vicinity of the maxilla. So you spoke about the paresthesias, as Dr. Mani was asking you what else. So think of all the other nerves that are in the vicinity. It gives you a clue about the involvement of the bone in the vicinity of the nerve involved. So if you have got the infraorbital nerve involved, you know that it is the anterior cheek skin that will be numb. If you have the anterior inferior alveolar nerves, the posterior alveolar nerves involved, the location itself tells you. If your teeth in the incisor region and the gums are numb, you know that it is involving the anterior part. If the molar and the palate is numb, you know that the posterior inferior alveolar nerves are involved. So it gives you a location. It gives you an understanding of the extent.
Yeah.
As far as the extent of the lesion is concerned, the proptosis was a dead giveaway. So you need to focus on ophthalmic symptoms. You need to focus on the nasal symptoms. You didn't ask for any dental loosening. You never asked for any oral symptoms. Understand that maxillary sinus tumors are extremely rare. What is more common is oral cancer. And oral cancer can present with a similar swelling. So you need to ask for oral symptoms. And as Gayatri mentioned, you need to look at the infratemporal fossa, the postlateral wall involvement, and that will give rise to trismus.
All right. So Dr. Ramsumba Reddy, having said that, so let's say this patient had epiphora, or let's say this patient had diplopia. What would be your thinking?
It's a infraorbit, floor of orbit involvement. Roof of the maxilla involvement is there, sir. Proptosis and diplopia. Even that nasolacrimal duct in blocked epiphora will develop, sir. It's more of it signifies the involvement of roof of maxilla.
All right. So Gayatri, having said this, what are the signs you're going to now specifically look for on your physical examination? Can you list them, please?
Sir, swelling over the malar eminence,
and what specific signs could you look for? Can you tell us, please? Let's start with an orbital examination.
Sir, can you please repeat the question?
Can you hear me?
Yes, sir. Yes, sir. Please repeat, sir.
Vision. When vision acuity, we have to check, sir.
All right. So you want to check the vision?
Yes, sir.
So why you want to check the vision at the very beginning? So you're looking for an orbital apex involvement straight away, is it? Ram, you there?
Protrusion of eyeball, anything is there, we have to check, sir.
Yeah, so there is orbital involvement for sure. So there can be an anterior orbital involvement and there can be a posterior orbital involvement, isn't it?
Yes, sir.
So which is more common in maxillary tumors?
Anterior orbital involvement is more common.
So what are the signs would we elicit then? Ocular movements?
Yes, sir, ocular movements.
Okay. What else?
Proptosis of the eyeball will be there.
Gayatri, you're saying something?
Proptosis of the eyeball, sir.
Right. So you'll measure how much proptosis is it? Okay.
And there will be ectropion of the eyelid sometimes.
Come again?
Ectropion, sir. Ectropion.
Ectropion. Okay.
Displacement of eyeball is there.
All right. It could.
All
right. Never mind. Okay. So if orbital involvement is examined, what is the next examination would you like to go to?
Posterolateral involvement is there. Any?
What are the signs you look for?
Trismus,
right?
Yes, sir. Any trismus.
Okay.
So, Soba Reddy and Gayatri, just pay attention to what the moderator and Professor Pai were asking you.
Yes.
When you are asked about a particular organ which might have spread of disease, you're looking at symptoms and signs referable to that particular organ, right?
Yes.
When it comes to the orbit, what I believe Dr. Mani is trying to elicit are symptoms which can be divided into three kinds. One is involvement of structures of the eyeball and the surrounding structures. So in that, you will potentially get your conjunctival edema, chemosis, which is typically a hallmark of advanced maxillary malignancy. Also, structural involvement will entail, think of the structures that make up that organ. If the extraocular muscles are involved, you'll typically have a limitation of eyeball movement, and it depends on whether or not that is because of direct infiltration of muscles or because it is because of a direct neural involvement. Like Dr. Mani was pointing out, involvement of the orbital apex might produce incomplete or complete ophthalmoplegia depending upon number of nerves involved and the types of nerves involved. When we talk about functional symptoms, which is our second type, that will typically entail involvement of your neural structures. Involvement of the optic nerve, which typically is a sign of very advanced sinonasal malignancy, will typically give you loss of vision. And it will not just give you diplopia in different cardinal positions of gaze, but will give you in the primary cardinal position, you'll start having loss of vision. So that's where you start getting concerned about much more advanced disease. In this particular, so answer your question that way. In this particular patient, you already know, and this is a point to Subba Reddy's partially answered question, that when you have, we've been historically, ever since the Ongren line and since the subsequently elegantly defined tissue planes, we already know that inferolateral orbital involvement is going to typically have a better prognosis than superomedial involvement. So when you have a malar eminence in a patient and you also have orbital involvement, that typically indicates that the inferior part of the orbit will be involved, and your symptoms and signs and questions will typically go in that direction. So just a clue to you to answer your questions in your examination.
All right. So we have to have some idea about how we are going to be specifically examine the extensions of this tumor at different surfaces of the maxilla. And this is what it shows. I mean, there is some proptosis, there is no diplopia. Nasal cavity examination is showing a fleshy mass, and the oral cavity is showing a palatal swelling. Okay. So what do you guys want to do from now onwards?
Contrast.
Mani, can I also ask what are the clinical examinations they would also do to complete that examination? Subba Reddy?
Yes, sir. Oral cavity examination and ear examination also has to be there. We have
What
to
in oral examination, what are you looking for particularly?
any upper alveolus, any lesion is there. Was the palatal movements are there.
And lastly, crossing midline.
Okay.
Okay, they extend across midline. So the teeth, there is a dentition, the bone, the palatal, and the hard palate, soft palate, the lateral extension, as well as coming out of the oropharynx. Go ahead.
In addition to what Professor Pai mentioned, Dr. Mani elicited from you, and the symptoms in the dialogue box, there are a couple of things which I believe have not been covered. Neck examination has not been covered so far. Remember, Gayatri, your first differential was a maxillary tumor. We may end up getting to that diagnosis based on the moderator slides. So make sure a neck examination is always included in that. Also, I think Subba Reddy pointed to dysesthesia. So we've not explored pain as much. I think your examiner, Professor Pai, was trying to take you in that direction. The site of the origin of pain and the radiations thereof will help you decide the site of origin of the tumor and the extensions thereof. So those two things I'd request you to keep in mind.
So what will be the next thing that you guys will do after you have a thorough clinical examination?
So cross-sectional imaging.
Contrast enhanced CT.
Non-contrast.
The base of the skull to the thoracic inlet.
Say that again. You want a CT scan?
Yes, sir. Contrast and enhanced CT scan, sir, from base of skull to the thoracic inlet.
Okay. What else? Anything else do we need?
MRI also is a complementary investigation to CT, sir, to know the soft tissue involvement.
So you would do both MRI
Yes,
and CT together?
Yes, sir. Because like he's also having orbital involvement. We know the soft tissue delineation well with MRI.
Excellent. Okay. So what do you kind of expect on this guy if we saw his MRI?
Sir, on like actually, like we should categorize it whether on the MRI it is looking P288 images.
Let Subbareddy just go for this CT scan because he asked for it first. This is a CT scan of this gentleman. You want to discuss this?
Yes, sir. The axial section of paranasal sinuses, sir.
Okay.
It is involving the entire soft tissue lesion involving the entire right left maxillary cavity, involving the entire orbit, sir, and then ethmoid region also involved, sir.
Did you say entire orbit?
It's extending into the orbits, sir.
Extending into the orbit is what you're saying. Okay. So what exactly are we specifically looking in a CT scan, which is going to add value to this investigation?
Posterolateral.
So would you want to comment about what is happening to the bony structures?
Yes, the bony erosions are seen in the CT. Expands the light lesion.
So you want to know whether if the bone is getting expanded, whether it is getting destroyed, whether it is getting remodeled, whether there is any other changes happening. So it's all related to all the bony and calcium deposits that we are keen to look at in the CT scan, isn't it?
Yes, sir.
So can you look at the CT again and see how the walls of the maxilla and various structures are affected by this mass?
Medial wall of maxilla is medial anterior wall of maxilla eroded, sir.
Okay. The examiners want to help them a bit.
Yeah, Subbareddy, what Dr. Mani is asking you is, when we are looking at a cross-sectional imaging, your intent is to identify what is the structure involved, that is the organ, and then look at all the extensions everywhere. So be very clear, look at superior, inferior, anterior, posterior, medial, and lateral. So look at that lesion. Look at the way it has gone from the first row, the fifth and sixth image. It has gone from superiorly, it is coming onto the ethmoids, possibly involving the orbit. The next scan, next row, right from the left-hand side, you can see that it's involving the ethmoid coming onto the postlateral wall. The postlateral wall is eroded. As you go down, you're seeing the pterygoid plate coming up. The pterygoid wedge is expanded. The postlateral wall is completely expanded. The anterior wall is eroded. It's coming on to the soft tissue compartment anteriorly. That means anterior wall is eroded. As you go down, you're seeing the alveolar process of the maxilla that is eroded, as well as the soft tissue coming on into the infratemporal fossa. So look at it sequentially, top to bottom, the way you want to, but do not miss any of these points. So now, critical to this event, to these sections, is the point of resectability. Can you tell me what is resectable and unresectable on a CT scan? Subbareddy. If not, Gayatri.
Sir, it is extending into the infratemporal fossa. So inferior extent like carotid vessels appear to be free, sir. So it is probably resectable tumor.
Next.
What defines unresectability, Gayatri, other than the involvement that you talked about? Is there any cranial nerve
yes, sir.
involved? You'd still consider resection. There's only one cranial nerve.
9, 10, 11, 12 cranial nerves, if they are involved by the tumor, it is also an unresectable tumor, sir.
So AJCC says cranial nerves other than V2. But
other than
V2. But that being said, multiple cranial nerve involvement is typically a very bad prognostic sign and would help you answer Professor Pai's question.
Yes.
Also, what are the other criteria of unresectability of sinonasal tumors that you can see on a CT? Only mention radiological criteria that would typically indicate unresectability on a CT.
So extensive brain parenchymal intracranial extensions, brain parenchymal involvement, and
Extensive ITF involvement, sir. Infratemporal fossa involvement.
Relative, yes.
Sphenoid sinus involvement, sir.
cavernous sinus involvement.
Extensive skin and soft tissue involvement.
Relative again, yes.
Positive retropharyngeal nodes.
Think medial and posterior. Think medial and posterior. Anything more medial and more posterior.
Orbital apex.
Cavernous sinus involvement is also.
Yeah, of course. We mentioned that already. Anything else? Nasopharynx and clivus is typically also considered a criteria for unresectability, and you can pick up clival erosion on a CT, and you can pick up nasopharyngeal involvement, even though soft tissue extent is better on an MR. And I think Dr. Mani put this on very deliberately because this is a classic case where you will probably need an MRI for surgical planning. But just one point prior to that, that when you talk about doing a CT and an MRI upfront, remember that we have not established a diagnosis yet the way this case is progressing. So prior to obtaining a biopsy, if you are in a resource stratified environment, you would be fine doing only a CT or only an MR and proceeding with a biopsy. Of course, if you need surgical planning, then all of us will tell you that you probably need a combination of that and locally advanced sinonasal malignancy. But for your workup, you can rely on one cross-sectional radiological modality and then proceed as well.
Yeah, Dr. Mani.
Dr. Mani, I think we lost your slides for a bit.
Yeah, can I think I've lost you guys. Okay, I'm on. Is there?
You need to share
your screen again.
Yeah. Yes.
I had a little connectivity problem here. Is it visible?
Yes. Yes.
Okay. So we were discussing the MR component. Can you hear me?
Yes, sir. Yes, sir.
All right.
Yes, we can hear you.
Yeah. So like Gayatri asked, we always have this CT and MRI as a complementary imaging, and here is the MRI. And would you guys now distinguish the information you obtained from CT scan versus MRI and see and compare what the differences are?
So in a T2-weighted images, it is hypointense lesion, sir. Is located hypointense lesion located in the maxillary antrum primarily, and it is extending into the left nasal cavity, and is also through the it is having soft tissue component beneath the skin.
So one of the things is Dr. Prathamesh was mentioning the extension into the ethmoids and other things. When you have a paranasal sinus nasal tumor, these osteums get clogged up and there will be a lot of secretions there. So when you take an MRI, you can distinguish between what exactly is the tumor and what is the other effects of clogging of this osteum. So can you make out this on the MRI? And now you can probably say how resectable it is.
Yes, sir. Actually, there are areas of hyperintensity, sir. Those may be due to the changes of post-obstructive changes. Yes, sir.
So just a point here, Gayatri, in response, in just adding to your question, to the answer to your question. You initially said hypointense. I'm glad you modified that answer somewhat. It's actually heterogeneously hyperintense, more or less. And the secretions that Dr. Mani wanted you to answer, the secretions are hyperintense typically on a T2 weighted image because they have higher
Yes.
water content.
Higher water.
So they'll appear hyperintense, as you can see in the superior part of the ethmoid, as he asked you to answer. But this is a very nice elucidation of how CT and MRI offer complementary information. Soft tissue detail is of course better in the MRI. Why don't you guys tell us how you will pick up information regarding the multiple cranial nerve involvement on an MRI? Would you ask for more images? What sequences would you ask for? And how will you make a decision regarding cranial nerve involvement in a maxillary tumor in an MRI?
So the widening of the neural foramen.
Post contrast with fat suppression images needed, sir.
So what is the clinical sign that Samit is asking? In the MRI, what is the clinical sign you're looking for?
Widening of the neural foramen.
The foramen widening,
Yes.
or what
Thickening
about the
of
nerve itself?
thickening of nerves, sir.
All right. So you can either have thickening of the nerve, or you can indirectly have the widening of the foramen, or you can see the fat between the bone and the nerve getting obliterated. So those are the signs which will, but exactly which nerve are we talking about, and which section would you go to look for this?
Optic nerve involvement.
Optic nerve. All right. So is it visible on one of these scans? Is the optic nerve visible? And do you
Yes,
think
sir.
the optic nerve is involved, not involved? Do you have that section here? I can see it. And I can add once more that the physical examination is a vision acuity is 6/6, and there is no diplopia in this patient. Okay, you can see the very last image on the right-hand side corner, third row. You can see that the optic nerve is clearly there and unaffected by the tumor. And you can see the ethmoids all clogged up with secretions. So the next important area where we look for nerves will be what?
ITS.
Sorry?
ITS, intertemporal fossa.
Coronal sectionless.
You need coronal section. Okay, I didn't get all the images for you, but basically we are going to very keenly look for all the divisions of the fifth nerve, and we are going to look for the cavernous sinus. So where would you look for cavernous sinus, and is it visible in the scan?
Yes, sir.
Reddy, can you just tell us which are the sections you look for?
Yeah.
Here, sir.
The cavernous sinus.
This is the cavernous sinus.
The last row, which sections?
First and second.
So it is your last three images on the in your from the right hand side.
Third images.
Yes, last three images on your right hand side, last row. So you're going to look out for the expansion of the cavernous sinus. You're going to look out for expansion of the lesion into the posterior part of the orbit. So as Shamit was trying to ask you, what part of the orbit is involved initially? So we know that this patient has proptosis. So we want to know whether the orbit is involved anteriorly or posteriorly. So we know that it is not involving posterior. That indicates that there is no ophthalmic artery involvement, carotid artery involvement, and possibly you can resect this without endangering these structures during surgery. Another important thing that we had seen was a posterolateral wall, the pterygopalatine expansion. So can you comment on the pterygopalatine involvement in this on MRI? Gayatri?
It's not involved, so it's free, sir.
How do you know it?
Second rows.
How do you know
second?
Fourth row. First
No,
row.
what are your criteria to know that the pterygopalatine structure, pterygopalatine fossa is not involved?
Both the pterygoid plates.
It's an MRI. We saw on the imaging on the CT scan that the plates were widened and eroded in few sections. On MRI, what are you trying to evaluate? You're going to look out for any fat planes. You're going to look out for any foramina involvement. You're going to look out for extensions along the nerves. So that's what Shamit was trying to elucidate about the cranial nerve involvements. So you need to look at whether there's a fat plane maintained, whether there is erosion into the foramen rotundum, as well as a median, and going along the inferior orbital fissure. So these are three areas where you like look out for extension, which will suggest that you might leave behind disease during surgery.
Gayatri, you had mentioned the lower cranial nerves, but
Yes.
remember that when you come to elucidation of a maxillary tumor, you want to look at not just the main trunks of the cranial nerves, but as Professor Pai pointed out, you want to look at the nerve of the Widening canal. You want to look at V2 very closely, going all the way up to the foramen rotundum. As one of you correctly pointed out, you would want coronal images. I think Subba Reddy mentioned that. That being said, you are expected to frame an answer with the images that have been given to you on a best guess scenario. Yes, you can say that you are limited by the fact that you don't have those images, but the answer still needs to be provided.
Okay.
In extension to what Professor Pai mentioned, look at the third image in the second row where you'll be able to see the fat in the infratemporal fossa having normal stranding or the normal signal compared to the opposite side where it just seems a little obliterated. And fat stranding, perineural enhancement, nerve thickening in your cross-sectional MRI will typically give you an idea about nerve involvement from your sinonasal cancer.
Okay, so here is your coronal image.
Sir.
So what will you do next?
Gayatri, you want to comment on this? Did you have a clue based on looking at the MRI itself?
Perineural infiltration.
Sorry?
Adenoid cystic carcinoma. Perineural infiltration. You have to look for perineural infiltration. Yes?
How will you look for perineural invasion on this section? This is just a section from a biopsy slide. Subbaredi, we want to add a few things on this tumor. Anything that you find interesting this tumor? She said this tumor has a predilection to catch the nerves, which is good. Anything else that you would like to know or add?
Since you guys have already obtained a CT as well as an MR for potential surgical planning and also to get anatomical extent of disease, you would want to look in retrospect now. The biopsy, as the moderator shared with you, is adenoid cystic carcinoma. So you want to look at intraneural and perineural skip metastasis. They may or may not be going all the way up to the skull base, but this kind of tumor is notorious for leaving an intraneural metastasis close to the skull base, which might not be anatomically contiguous with the lesion as per your radiology. So you want to clear this tumor because Professor Pai was asking you about your surgical decision making all along. You want to make sure that this particular tumor is cleared all the way up to negative nerve margins. And I believe that's what the moderator is trying to elicit from you. When you get a biopsy like this, you go to the radiological hallmarks of that tumor, if any, and then try to get even more information over and above whatever you've already gotten from your index examination of the radiology.
Now, what is the staging system we should use now, Dr. Subbaredi? Now we have a maxillary tumor and we have a biopsy report. So what is the staging system we should use for this?
AJSC, sir.
Yeah, but do you use staging system exactly as in the squamous cell carcinoma? Is it any different? Would you use it like it was in the oral cavity? So you can have an adenoid carcinoma in the submandibular gland. You can have it in the tongue, buccal mucosa, palate, isn't it?
We use it according to the HSC system for
Right.
squamous
So
cell
it is the
carcinoma.
same. I mean, the fact that the salivary origin does not change the staging system. It is still like any other maxillary tumor. Is there any tumors in the maxilla that would not fall into this staging system?
Lymphomas, sir.
Good. What else?
Sarcomas, sir.
Excellent. Right. So that summarizes it. Okay. So we have to be careful that we stage the tumor according to what the biopsy shows. Now, what else would you want to do now that we have the CTMR and the biopsy?
Is there any other information you need prior to final staging or assigning a final stage?
Yes, sir. Adenoid cystic is a highly malignant tumor, so we would like to know the distant metastasis of the CT chest.
Yeah. Okay. And I don't know if in answer to Dr. Mani's question, if you guys said esthesioneuroblastoma, but that has a different staging system as well.
Yeah.
Right? Talking about malignancies.
So yes, so this patient had evaluation of the chest as well. So that is normal. Okay, if you wanted, he came to us with a PET scan, which was normal elsewhere. So it is a M0 based on imaging. So what would you want to plan for this patient?
First, we have to plan for resection and then reconstruction accordingly.
What's the complete plan, please?
Total maxillectomy.
Go ahead. Yeah.
With the inferior alveolar process involvement, either obturator or
No, sorry, did we do the tumor staging? The N and M are 0. Okay, you wanted AJCC, so it is N0, M0. What is the T stage? And
he says T4, T3s.
T4As, the
T4As.
pterygoid plates are involved.
good. Examiners would agree?
Yeah.
All right. So we are talking about a T4A, N0, M0 tumor, and you're planning for surgery first, isn't it?
Yes.
Anybody wants to give a neoadjuvant treatment for this patient?
In adenoid cystic carcinoma, there is no roles.
Excellent.
Is there, Subba Reddy, let me ask you an extension to that question and to your comment. Is there any sinonasal carcinoma which is resectable in which there is a role for neoadjuvant chemotherapy?
It's a squamous cell carcinoma involving the only orbital floor not extending. Orbital fat, we can do in borderline operable. We can give NACTs.
How do you define borderline operable in sinonasal cancer based on orbital involvement, which you are trying to use as a yardstick? The question is fairly simple. Do you consider neoadjuvant chemotherapy in resectable sinonasal cancers?
In orbital any functional preservation, we can use NACTs.
What is the literature that we are quoting?
TMH.
The authority is with us, so he can comment.
What study is Dr. Shamit asking you? Is there any data on that?
Resectable carcinomas of the sinonasal region, the role of neoadjuvant chemotherapy with the endpoint of orbital preservation. Is there any study?
Exactly, I don't know, sir.
Okay. So be very careful. This is classically what you would call as an examiner delight. You are pushing yourself into a situation which will become difficult to do. Your moderator has already mentioned a surgical plan as potential line of management. You have to toe that line because that is essentially what is standard of care in this particular scenario. Let me backtrack one thing. I think Dr. Mani probably did it in the interest of time, but there was a very nice point in his last slide in which he mentioned whether any additional tests are required.
Yeah, that's right.
Or whether any pathology would be a determinant. Is there anything in pathology of this particular tumor that you would be asking your pathologist that what exactly are we dealing with? Even within adenoid cystic carcinoma, is there any other information that you need?
So I'm on, we have 15 more minutes. So if we can pull up faster, we could get through with another one or two cases.
Yeah, so because we are supposed to help them along as well. So the classic three variants are cribriform, trabecular, which is also called tubular, and solid. So you want to, and the severity and the aggressiveness goes on. So you want to ask them about the pathological variant. Some people get a Ki-67 score. The role of that is only for prognostication, does not have a role in decision making. So that's probably what the moderator wanted when he put up this slide. Yeah, let's move on. Surgery, you said. Extent of surgery needs to be better defined. You only mentioned a total maxillectomy and you went ahead with obturation, which is a separate topic altogether. Gayatri, do you want to tell us about the exact surgical extent of the disease? Of the operation, I mean.
Yes, sir. Total maxillectomy, sir, along with orbital floor. As we'll be excising the orbital floor, also like we'll put a temporary sling to prevent the eyeball from.
So remain limited to the surgical resection, and then we hopefully Dr. Toprani will give us 2 minutes to discuss reconstruction.
Yes.
The surgical extent will also entail an infratemporal fossa clearance, as Professor Pai told you. The soft tissue extent of the adenoid cystic carcinoma extends into the infratemporal fossa through the posterolateral wall of the maxilla. So that needs to be cleared. You will have to do an ethmoidectomy, not only for making sure that you have adequate mucosal clearance, but an ethmoidectomy either en bloc or otherwise would probably be indicated. An orbital clearance versus exenteration. Subbareddy, what would be your choice? Do you understand the terms orbital clearance versus orbital exenteration, and which one would you choose in this particular case?
Orbital clearance, I will choose, sir.
Okay. Okay. And how will you ascertain that you finished a complete resection job? How will you make sure that your orbital clearance is successful? Any intraoperative indicators that you'll use to make sure that your orbital clearance has actually managed to encompass all disease?
Frozen section of the margin.
Okay. And you can send it from what structures can you send it from? Orbital fat typically does not lend itself very well, but you can try typically periorbita or extraocular muscle. But remember, the more extraocular muscle you start excising, the more non-functional you are entering the orbit. So your preoperative counseling for a patient who has orbital involvement, not necessarily globe involvement, would be to counsel them for a potential orbital exenteration, even if you're planning with the orbital clearance. So that's the right answer, Subbareddy, but it needs to be elucidated better.
Consent has to be there to exenterate the orbit, before which you can't go for a surgery in this patient. And this is what this patient had. So there is about this orbital sling. Can you comment on that other X-ray, Dr. Gayatri? There's an X-ray there.
Yes, sir.
You want to comment what is used for that particular patient?
Mesh.
You can see that, right? So
yes.
You could do either this or you could do the just
temporary
sling. Dr. Ram Subbareddy, would you want to tell us what this is?
Right side is the operator replacement, sir.
All right. Okay. So what do you guys do next after doing your operation?
Based on the post-operative histopathology, plan for adjuvant radiotherapy.
So the pathology is all clear, all margins are clear, and this is cruciform variant of adenoid cystic. And what else would you need?
Follow.
What will be your discussion with the radiation oncologist in order to plan the radiation portals? Would you be discussing or you leave it to them?
Okay, this picture does not belong to this patient. So can you tell us why this doesn't belong to this patient? Let's say even if we had given radiation for the gentleman, what would be the giveaway when you see this picture?
It's the right side, sir.
No, all right, that's okay. That's obvious answer. But what more technically can you tell us? That means you know to read how to, interpret the isodose curve.
Radiation field included the other side also.
The radiation field is including what? Just to see how much of neck has been included for the radiation.
Yes.
Would you do this for an adenocystic carcinoma?
Yes.
A 90% depth dose involving both sides of the neck for a maxillary adenocystic carcinoma? We'll never do that, right? So that's exactly why you should clearly say that this is. Of course, obvious thing is what Ram Subbareddy says, is right and left. Okay.
Gayatri, what is GTV, CTV, and PTV? Are you familiar with those terms?
Gross tumor volume, critical tumor volume.
Good. And PTV is?
So before you do radiation, you do radiation what? You do radiation planning, right? Planning treatment volume, right? Yeah. Are there any maxillectomy defect classifications that you know of?
Brown's classification, modified Brown's classification is there, sir.
Okay. Any other classification, Gayatri, that you're aware of? Something that's widely used? He's given the first correct answer. Brown's classification is used the most.
I'm not sure about maxillary defects.
Okay. There's another relatively widely used classification by Dr. Okai and Arken. So Okai-Arken classification is also used, but Brown's classification, if you get it, you'll get good marks in here. What about choice of lab?
Needed to intervene there about the radiation portals. You need to discuss in adenoid cystic tumors, particularly because of perineural spread. You need to ask your radiation oncologist to cover all the areas where the nerves would be exiting. So the radiation oncologist should cover the V2, V3 routes because those are very close. We also know that the pterygopalatine fossa was effaced. So this discussion should happen with the radiation therapist. Yeah, Shamin, go on.
What are the, I just have one question and maybe Dr. Mani can help answer the unanswered questions and we can probably chip in. With regard to sinonasal reconstruction, a nice flap was selected. The patient seems to have a great outcome, early postoperative outcome. What are the goals of sinonasal reconstruction? And just be very brief in these answers. Mention 6 or 7 goals that you think should be the outcome of sinonasal reconstruction. We're not talking obturation. We're talking about if you put a flap in there, what all are you hoping to achieve?
So first of all, like if there is a craniofacial resection, we should be able to completely patch the dura, sir. So there should not be any CSF fibronia or leak.
So CNS separation, that is one aim. Go ahead. Other aim.
Sir. And the other is oronasal separation, sir.
Okay, oronasal separation. Okay, yes. Go ahead.
And cheek flap, cheek prominence.
So
soft tissue coverage, extensive soft tissue coverage.
Okay, so you should not have a loss of cheek bulge, or you should have a cheek prominence or some form to the cheek. Anything else?
Yes, sir. And orbital reconstruction to the patient.
Okay, so you want to avoid orbital dystopia. Okay, yes, anything else?
And that he should be in his follow-up, recurrences should be easily detectable.
No, so in the age of advanced diagnostic techniques, I think the first 4 answers were absolutely correct, but normally leaving a cavity open, that essentially what you're hoping for will leave a cavity open to repeated examinations. And that's probably not going to be concordant with your aim of permanent oronasal separation, correct?
Yes.
So yes, you want to be able to monitor to whatever extent. You want to not occlude the nasal cavity, even though it's something easier said than done. Sometimes you have to do it.
Yes.
Any aims with regard to the lacrimal apparatus? If you manage to preserve the eye, that needs to be. Okay.
Marsupialization of the nasal.
And then I think you mentioned orbital support, but we did not mention ectropion. Your incision is key to selection and prevention of ectropion and epiphora eventually. Okay. Any other basic aims, Professor Mani, that you wanted to add? Yeah, restoration of dentition, which you can do with a bone-containing free flap. All right.
There is one question in the chat box.
Yeah.
Would you consider doing a coronectomy? If yes, why? If not, why?
This case, the coronectomy was done as part of the temporal sling, so that comes free. But in a patient who didn't have a trismus to begin with, and anyway they're going to have a free tissue transfer, there is no rule for coronectomy specifically in this case. Oh, was it for the candidate or was it for us? All right, so it's a quick spotter. I mean, I don't want you guys to spend just that, here we saw one 25-year-old lady with, was lactating with a 5-month-old child, some swelling like this in the malar region. And the open mouth view is also there. So what comes to your mind? Let me have a clinical differential. Just because, there is anything that strikes your mind?
One thing I can put in minor cerebral gland tumor, sir.
All right. Ram, anything?
Ameloblastomas.
Really? Why? Why did he go for that? Just because she's lactating, why should she get ameloblastomas? Would you want to look at anything else which are...
angiofibroma.
Angiofibroma? Really?
Female.
No, sir. No, sir. No, sir.
Okay, so you want a CT scan? I'm going to give you a CT scan as well. So what do you guys see? So you're seeing some tumor with a lot of
chondroid matrix
calcification, right?
Yes.
Okay, so she came to us with the diagnosis of ameloblastoma, but we are not agreeable with that. So we'll wait to see what exactly it is with the final report. Okay, so I'm going to quickly go into one other aspect of this topic. So here is a guy who we operated in 17 for a buccal mucosal lesion, and he had post-op radiation because it was T2N1, I think, and he was on regular follow-up. And he has some pain complaints of the upper molar tooth since October last year. Oh, it's the year before, 2020. And then at that time, we went back and reviewed all the histology, the surgery, and we found that everything was in order. He did not have any discontinuation of treatment. The surgery was all good in terms of the biopsy report, etc. And so we were wondering why he's suddenly developing this pain. And then he comes up promptly with a discharging sinus on the left cheek swelling. So what do you guys think? It's a purulent sinus discharge.
Osteoradionecrosis.
So we all thought it was osteoradionecrosis, and then he did go on some medication, and subsequently again he got back this pain, and then he was advised to go for a extraction of the teeth, offending teeth in August last year. But then as soon as that was done, so what will you do now?
So we'll ask for a cross-sectional imaging.
So I don't think we should give away like that. We should continue to this. I'm sorry. Yeah.
We should
Yeah,
ask
we
for a
did do a
cross-sectional image.
cross-sectional image. Yeah, that's right. We did that. In March of 2021, we did the actually a PET scan itself. And then he had this indeterminate lesion there, which we biopsied, and that was negative. And so he was again on a course of antibiotics, and he was like this. So it was only this year, last month, that he came up with this kind of a picture, right? So from 17 to 22, now he has this picture. This time he has severe trismus, and then you examine, there is a oroventral fistula with a growth in there. So what do you guys think we should do now?
Biopsy, we have to confirm the.
Yeah, so biopsy is done, and it is squamous cell carcinoma, moderately differentiated.
Then extent of disease we have to know, sir.
Right, so we did a PET and MRI, and that is the extent of the disease. What will be your approach, and how will this the approach for this patient be different from the first patient we discussed?
Yes, sir.
Yeah, I think the examiners can take them through between the.
I think we can summarize with the comment from the examiners and to all, because there's going to be short of time.
So assuming it's probably the last slide, what would you typically do in recurrent squamous cell carcinoma of the head and neck? What is the standard investigation? It's already been done, and it shows a local recurrence with a DFI which is adequate. What is the next thing you'll do? And I think that's what the moderator is trying to ask of you. You have a disease which has not a very good prognosis anymore. You have recurrent squamous cell cancer. It's already involving, by virtue of the ITF being violated, the patient already had an upper alveolar resection. We are now dealing with a pterygoid plate involvement, so recurrent cancer of the infratemporal fossa. In addition to PET CT, and think more broad-minded now, in addition to a PET CT which has already been done, what else will you do before you plan the patient for any kind of therapy? So, Bharati.
Performance status.
Okay, good. So performance status of the patient, a review of their expectations, what they are expecting from their outcomes, and a very, very holistic view at what the survival rates are going to be. That would be the norm. I think I'll just ask one question about the spotter and then turn it over to Professor Pai for his comments, and then to Professor Tuprani. Dr. Mani showed you as a spotter a midline palatal swelling. Before he showed you the radiological investigations, please tell us your differential diagnosis of a midline palatal swelling.
First one is a minor salivary gland tumor, sir.
You mentioned that already, so that's done. Anything else? Think about lesions which are typically in midline. Think about lesions which are very innocuous.
Sarcoma, sir.
So a sarcoma does not have a midline predilection. Your patient eventually had a sarcoma, probably, that we were looking at, potentially a chondrosarcoma, but again, it could be anything on the spectrum of sarcoma. You look at palatine tori, something very innocuous, but sometimes people end up biopsying them. When they come to your tertiary center, you need to make sure that that you rule that out. Dermoids in the midline are something you always need to rule out. So when you look at midline palatal swelling, there are only a few differential diagnoses. So don't tangent. You mentioned angiofibroma. All of us know that the origin is the base of the pterygoid plate, usually ipsilateral. So you don't really want to go into that territory. Yeah. Thanks. That's it from my side.
So I would just like to ask about these recurrent tumors. When you look at these recurrent tumors, what is your plan? When you do an imaging and subsequent do a planning, what is your focus on staging, and what is your focus on the treatment options thereafter? Take this case in point with Dr. Mani has put up. How will you do the recurrent staging? Can you tell us the criteria for calling it recurrent, one, and how do you stage it?
Oh,
Gayatri?
sir, within 6 months of the surgery.
Patient was operated in 2017 and now thereafter had a recurrence, possibly recurrence in 2021. Patient has received adjuvant radiation prior. So it is very critical for us to know what is the disease-free interval. And you need to, as someone has rightly mentioned, you need to have the R staging. So whenever you're talking of recurrent tumors, you need to be very clear, going by the Warden and Gates criteria. Where are the what is the site of the lesion? What are the disease-free interval? Whether it is the same histology, whether it is the same location. And thereafter you look at what is the structures involved and plan it according, you stage it according to your TNM. So your recurrent, this was a recurrent T4B lesion. Patient has already received radiation. So now, as Dr. Shamit asked you, what would be your plan of treatment? So based on whether the possibility of a complete clearance is there or not, two, whether you can actually give adjuvant therapy, that determines what is the prognosis of this patient. So whenever we look at recurrent tumors, please go and follow the recurrent staging and plan the treatment accordingly. Thank you.
Dr. Mani, shall we conclude the case discussion, sir?
Yes, we are done.
Yeah, thank you so much, sir. So we would invite first you and then the other examiners to give your advice to the participants who have presented the case as well as to others, just to sum it up.
About their performance and what they could do better.
Dr. Mani?
Yeah, I think both of them did quite well. I understand that, when you're going in a virtual platform like this, there's so many people looking at you, there is an obvious anxiety involved. But I think we should try and get past that, and you guys really know well. Just have to crystallize the answers and put it more emphatically and confidently, so it is clear to the examiner that you know what you're talking about. There are a few areas that you need to kind of strengthen in terms of anatomy and in terms of pathology, because that would be the key thing in discussing any maxillary tumor. So you can perhaps reinforce a little bit more on the anatomy and the pathology aspects of it.
Okay. I felt that both of them were a little inhibited, maybe because this is a different kind of a platform wherein you're not aware of the case, you're not taking your history yourself. But as Shamit had rightly pointed out, given by what you're seeing on the screen, you need to actually make a judgment call. You need to focus on the parameters that will allow you to give a diagnosis and then elaborate on what you're seeing. And I think stick to the basics. Don't go away from the basics. Things like clinical examination, symptom and sign correlation, as well as imaging is very critical. And have in mind what are the standard imaging options for different sites, locations, as well as what we can gain as key features from each of the imaging. And of course, standardize whenever we ask you about treatment plan, there has to be a standardized treatment plan. You need to focus on the primary resection, management of the neck, as well as reconstruction, followed by adjuvant therapy. So in oncology practice, it is relatively easier. So you need to focus on these aspects and then structure your answer accordingly. Thank you.
I completely concur. Incidentally, this was exactly the same feedback that I was going to give you. Remember, examinations are a point analysis, and they're supposed to encapsulate whatever you've done over the course of your curriculum and your years at your particular institution. So if you do a good basic answering, then in that case, you're typically safe, at least from an examination standpoint. Focus on your clinicals, try to get as much information, think on your feet in terms of trying to get as much information from the displayed radiology slide. And I completely concur on the treatment plan idea. You need to be very clear about what you're sending out. You need to make sure that whatever you are saying, you should be able to stand up to it. I think Subba Reddy went into a little bit of a pickle simply because he tried to answer something which he could not. With all due respect, Subba Reddy, I think you tried well. In that respect, I would request you to be completely focused, and that's what these academic activities are for. Kudos to IASO for taking this up, and I hope we are able to do it all four and all organizations. But this is exactly meant to prepare you. So I would take a number of positives out. Good job, and we hope for a better performance next time, of course.
Thank you so much, examiners. We go on to our next part. I invite our convener, Dr. Rao, to kindly give a small announcement.
I thought, with the permission of the President, I thought it's indeed important to thank the former advisors for their contribution. When we were about to kickstart the IASO Masterclass about a year back, a little more than a year back, we were under a bit of pressure because from one part of the country, it's not easy to run this program with so many members and so many organ systems. All of us are specializing, so there's a chance that you don't know some of the real leading lights well enough. So the IASO core leadership then decided to draw 4 advisors from 4 zones, and all of them are former presidents. So they know IASO and they know the ecosystem, how surgical oncology developed in the country. All of them seniors. Professor Arun Chaturvedi from the north, Lalatendu Sarangi from the east, Professor Rajaraman from the south, and Professor Kiran Kotari from the west. I think I can't thank these 4 gentlemen enough for the resounding success. First year has been, would always be the most important, and their role cannot be undermined. They were very active and accommodative. They showed great camaraderie. They gave space to a bit younger people like me and much more younger person like Sajan Shukla. And then they were very, very impartial as far as choosing the examiners and the students were. I think with the new team, with equally wonderful people, we'll be having Harit Chaturvedi, Professor Sanjay Kapoor, Dr. Hemant Raj, and Dr. Sanjay Sharma coming in from various zones. We welcome them. We are going to miss the advisors for the last year. We know they'll not be in the center stage, but we understand that they've been a very strong part of IASO, and they'll continue to be our advisors and continue to show us the path. Thank you very much for being there, 4 of you, sirs. Jai IASO.
Dr. Rao, I cannot thank you. I must thank you and Srijan also for having done these activities for last more than 1.5 years now. Thank you. And please continue doing a great job for
Truly appreciate your leadership, Rajendra.
With that, now I invite Dr. Caleb Harris, the organizing secretary of MidCon IASO. We'll be showing a short video first, following which we'll ask him to speak.
The Indian Association of Surgical Oncology is glad to invite you to Shillong to the midterm IASO conference to be held from 25th to 27th March 2022. The theme for this conference is Skill Sets in Surgical Oncology. We will have the experts in the field coming in and sharing their experiences and tips and tricks on how to acquire the various skills required for a surgical oncologist. While Omicron might have hit us hard, I'm sure we have all emerged stronger. And armed with more antibodies, I'm sure we are all ready to travel. So come and experience the conference and also visit this beautiful part of our country, the root bridges and caves at Cherrapunji, the Mawphlung, Sacred Grove, and many other wonderful places. Welcome to Shillong.
Good evening, everyone. I want to extend a very warm welcome to all of you to come to Shillong to be part of this conference. While Shillong is really an attractive place, I'm sure what will be more attractive will be the scientific program, because unlike many other conferences, this is not going to be a routine multidisciplinary conference. It's going to focus on skill sets, and this is something which will be really very, very beneficial to all residents and younger surgeons. And I want to mention the point that generally we assume that skills are just acquired by observing someone, but I truly believe that a real teacher can really be able to impart even the skills, and that is what is going to happen in this conference. So I invite you all once again, and feel free to contact me if you have any queries. I'll be glad to help you out. Thank you. Over to Dr. Ravi Kannan. He'll have a word.
Hi, everybody. I want to add to what Caleb said. We're trying something different this time, and I think it will be of immense benefit for younger surgeons and residents. And so please take this opportunity, visit us, visit the Northeast, visit Shillong, and participate in the meeting. I think we can make it a good meeting. Thank you.
Caleb is doing a wonderful job, and he has worked hard to make this a successful meeting. And I would urge all my IASO members to support him and participate in this meeting and make it a huge success. And we'll be meeting in person after a gap of almost 2.5 years. So that will be an added attraction. Looking forward to see you all at Shillong.
Thank you. We move now to the next segment, which is the statistics and research methodology primer segment. The talk for today is odds ratio versus relative risk, and it will be delivered by Professor Narendra Kulikar from SWIMS Tirupati.
Good evening, everyone. At the outset, let me thank Academic Council of Indian Institute of Surgical Oncology for giving me this opportunity. Today's my talk is about odds ratio versus relative risk. Aren't they oddly similar? Superficially, the answer to that question is yes, they are similar, because both of them measure association between cause and effect. But there is some minor difference which I am going to tell you throughout my talk. Odds ratio is basically a ratio of two odds, and relative risk is a ratio of two probabilities. So before going in detail about relative risk and odds ratio, we should understand what is risk and what is odds. Basically, risk is the probability of occurrence of an event or an outcome. For example, if I toss a coin, what is the risk of getting heads? The risk or the probability of getting head is there is only one chance out of two chances. So 1 by 2, or it is 0.5, or you can call it as 50%. Similarly, if you roll a dice, and what is the chance or the risk of getting 3? It is 1 by 6. Odds is something different. People who are into gambling, betting, they know this word better. So odds is basically a ratio between probability of occurrence of an event to the probability of the event not occurring. In the same coin tossing scenario, the odds will be 1, because probability of head getting head is only 1, and the probability of head not getting is 1. So 1 by 1 comes out to be 1. If I am playing, for example, a snake and ladder game, which is very famous. So if I am at 97, so I am worried whether I will get 1. So that if I get 1, I will be in 98, which brings me down to number 5. So while rolling the dice, I will calculate what is the risk of me getting 1. Then the probability of getting is 1 by 6, very remote. For the same scenario, if I calculate odds, then it will be, odds will be the chance of getting, probability of getting 1 is 1 by 6. Probability of not getting is 5 by 6. So 1 by 6 divided by 5 by 6. That comes to 1 by 5, around 0.2. That's how odds is calculated. Let us take an hypothetical vaccine study. For example, it's a randomized control study wherein we have taken certain number of people. One group is vaccinated and another group is not vaccinated. And we are going to study the outcome, that is development of severe disease in both the groups. So this is depicted in this table. For example, there is A plus B number of vaccinated people are there and C plus D number of non-vaccinated people are there. Then we are going to observe over a period of time, say about 6 months or 1 year, for development of severe COVID disease. So then we are going to calculate the risk. Risk is given by the number of vaccinated people who develop the disease among those who are vaccinated. That gives a risk for the vaccinated group. That is A divided by A plus B. Let us take it as R1. Similarly, among the non-vaccinated people, it would be C by C plus D. That is R2. Then the relative risk is calculated by the ratio between R1 and R2. So A divided by A plus B, then C divided by C plus D. Whereas odds is given by A divided by B, that is the O1, whereas C divided by D, that is O2. And the odds ratio is the ratio between O1 and O2, which comes out to be AD by BC. So basically, relative risk is probability of an event, usually a disease, occurring in exposed people compared to the probability of the event in non-exposed people. Usually, it is taken as a ratio between the two incidence in exposed persons to the incidence in non-exposed person. Relative risk can be calculated only in cohort studies or prospective studies. In case control studies, we won't get incidence because already disease has happened. Coming to the interpretation of the relative risk, as well as interpretation of odds ratio are similar. When the value is 1, the risk in exposed is equal to the risk in non-exposed. There is no association. If it is more than 1, risk in exposed group is more than risk in non-exposed, and that is called as positive association. If it is less than 1, risk in exposed is less than the risk in non-exposed. Usually it is taken as negative association or probably a protective factor. Epidemiologists interpret various values of the relative risk differently. If it is more than 1.5, it is taken as moderate to strong. Between 1.2 to 1.2 to 1.5, it is weak. Between 0.9 to 1.2, they consider the association is none. Between 0.7 to 0.9, again, the association is weak, and less than 0.7, and association is supposed to be moderate to strong, and it is a protective, usually it is considered as protective. So again, the same formula I have explained here, how to calculate relative risk. Basically, it is the incidence in exposed divided by incidence in non-exposed, which comes to be A divided by A plus B divided by C divided by C plus D. So that is the formula. So let us take an example. It's a cohort study where we have taken a certain group of smokers and non-smokers. 2 cohorts we have taken, and we are observing them for the development of coronary heart disease over a period of time. For example, 84 patients out of 3,000 patients develop coronary heart disease among the smokers. Then the incidence is calculated as 84 divided by 3,000, which comes out to be 28. Similarly, in the non-smokers, it is 87 divided by 5,000, which comes to 17.4. Then the relative risk is obtained by dividing the risk in exposed, that is 28, divided by incidence in non-exposed, that is 17.4. It comes to be 1.67. That's how relative risk is calculated. Odds ratio is basically odds of an event is defined as the ratio of the number of ways the event can occur to the number of ways the event cannot occur. For example, let us take what is the odds of Mumbai Indians winning the IPL 22 is the question. Suppose we take that probability of them winning is 60%. then obviously we can calculate probability of not winning, that is 40%. So the odds is calculated, odds of RCB winning IPL 22 is calculated by 60 divided by 40, which comes out to 1.5. So there is a difference between the probability and the odds. You can understand like that. So basically we are counting the chance of winning divided by chance of not winning. So odds ratio for cohort study is defined as ratio of odds of development of disease in exposed persons to the odds of development of disease in non-exposed persons. Similarly, in a case control study, it is defined as the ratio of the odds that cases were exposed to the odds that controls were exposed. So this table depicts how we calculate odds ratio in a cohort study, and this table in case control study. Basically, as I said, odds ratio involves odds that an exposed person develops the disease divided by odds that a non-exposed person develops the disease. So that's given by the formula A divided by B divided by C divided by D, which finally turns out to be AD divided BC. Similarly, in case control study, it is taken as odds that a case was exposed to the odds that a control was exposed. Finally, it turns out to be AD by BC. So basically, odds ratio is nothing but cross product ratio, that is AD divided by BC in both case control and cohort studies. So interpretation of the odds ratio is similar to that in relative risk. So it depends whether it is less than 1, equal to 1, or more than 1. So odds ratio is used both in case control and cohort studies, that is prospective as well as retrospective studies. So let us take an example from a case control study. For example, we have taken coronary heart disease patients and certain controls, and we are looking for the history of exposure to smoking. So suppose there are 112 patients of coronary heart disease have smoking history, whereas 88 do not have non-smoking history. Then how do you calculate odds ratio? It is taken by the cross-predictive ratio, that is 112 into 224 divided by 86 into 176, it comes out to 1.62. So now coming to today's question, whether they are similar. For example, for a cohort study, I have calculated in two scenarios when the disease is not so common and disease is common. When disease is not so common, the relative risk almost is equal to or approximately equal to odds ratio. For example, I have taken a certain rare disease wherein only 200 of the 10,000 among the exposed developed disease and 100 of the 10,000 among non-exposed developed disease. Relative risk is calculated as 2 and odds ratio is calculated as 2.02. Both are almost similar. When the disease is frequent or more common, suppose 50 out of the 100 develop the disease and 25 out of the 100 among the non-exposed develop the disease, then the relative risk comes out to be 2 and odds ratio comes out to be 3. They are dissimilar. So the point here is when the odds ratio will be equal to relative risk, these three conditions have to be met. One, the disease should be rare, it should not occur frequently. Then the cases studied should be representative of all the people with the disease in the population, and the controls also should be representative with regard to history of exposure of all the people without any disease in the population from which the cases are drawn. We can also estimate p-value for both relative risk and odds ratio by drawing confidence interval. When the confidence interval is small and the lower limit does not overlap with the odds ratio of 1, it is taken as significant. So finally, to summarize, odds ratio and relative risk both measure the association, that is between the cause and effect, and interpretations are similar. Relative risk cannot be used for case control studies or retrospective studies, whereas odds ratio can be used for both prospective studies as well as case control studies and retrospective studies. When the disease is infrequent, particularly in a prospective or cohort study, odds ratio is a good estimate of the relative risk. Even sometimes some reputed journals make the mistake of reporting or confusing relative risk with odds ratio for even retrospective studies. Thank you very much. Again, I would like to thank the Academic Council for giving me this opportunity. Thank you.
Thank you, Dr. Narendra. We now invite Professor Prathamesh Pai to kindly deliver his expert talk on maxillary tumors today. Professor Pai.
Can you hear me now?
Yes.
Yeah. Thank you very much, Dr.
You're not audible.
Fadi and the team for inviting me for this session. My mandate is to speak to you about the contemporary management of maxillary sinus tumors. So I will be focusing on a few things which would be of interest to the residents as well as the younger consultants. We all know that the tumors of the nose and paranasal sinus are extremely rare, and as we saw today, that shouldn't be our first diagnosis when we're looking at swellings in the nose and the paranasal sinus tumors. However, in the paranasal sinus tumors, they're more likely to be malignant, and that should alert us. It is predominantly seen in the older population. This exposure to wood and industrial fumes is of academic interest. We rarely see that in practice. And of course, cigarette and alcohol consumption have not been significantly shown to be the cause for these lesions. Most of our lesions occur in the maxillary sinus, in the paranasal sinuses. However, we are seeing more and more the nasal and paranasal sinus tumors in the past decade. They do present with symptoms, as we discussed today: oral, nasal, ocular, and facial. And most of them will have a combination of all four of them, and it is incumbent on us to elicit these presentations. Now, imaging is very critical to paranasal sinus tumors because we want to know the possible pathology, the extent of spread, as well as the involvement of surrounding structures. The X-rays are relegated to the past because they do not give us adequate information. Of interest is this Orngren's line, which was proposed way back in 1933 by George Orngren, which divided the lesions as suprastructure and infrastructure. And obviously the suprastructure ones presented late and had ominous outcomes because of involvement of the orbit, brain, etc. Now, CT scan remains the investigation of choice, and a contrast enhanced scan is what we should order. We should ask for the multi-detector scans giving us the thin cuts. So the 0.63 mm cuts give you a better roadmap for surgery and to evaluate the surrounding structures. We always get these kind of images on the CT scan, which tells us about the soft tissue involvement of soft tissue swellings in the paranasal sinus tumors, and we're often wondering whether these are pent-up secretions. The pterygopalatine fossa is also seems to be, effaced at times, and then we are left to wonder whether it's actually involved. We do compare it with the contralateral, but we would like to know, as in today's case, whether an adenoid cystic is something, though involving these areas, are amenable for surgery. Infratemporal fossa, again, in a patient who is diabetic, who is aged and having infection, gives us a false impression. So it's incumbent that we do a complementary MRI today and get proper imaging details and correlate bone and soft tissue. We want to know about retained secretions, as we saw in the lesion today, which had pent-up secretions in the sinus and was not necessarily involving the frontal and the intracranial structures. We would like to know more about the delineation of the dura. With that, it is critical to know whether we want to go intracranially. We would like to know more about the orbital involvements, whether it's actually involving the orbit or is it just effacing and demineralizing the bone. We would like to know more about the pterygopalatine fossa and the infratemporal fossa. And these are, MRI gives us clear delineation whether it's actually involved. today we cannot proceed without knowing what is the histology. And histology is the key to the treatment management of sinonasal and anterior skull base tumors. When you look at large case series, and I draw your attention to this from the National Cancer Institute in Milan, they evaluated 704 patients. And when you look at the ethmoid sinuses and the maxillary sinus, we are being taught to understand that squamous cell cancers would be the most common entity. But to our surprise, we find that majority are non-squamous. And it is no longer adequate to know whether it's an adenocarcinoma. We need to do further immunohistochemistry. We need to do molecular testing today in order to know more about the type, the grade, and what is the prognostication for the patient. We need to understand that there are certain chemosensitive tumors, and surgery may not be a role in these tumors. Germ cell tumors, for instance, you might come across Ewing sarcomas and abdominal sarcomas where we know that surgery is not the first line of treatment. So it's incumbent today not only to get a biopsy, but get immunohistochemistry. You might have a change of management. You might need to do metastatic workup. You may need to plan for chemotherapy in the neoadjuvant setting. You may need to counsel your patient that the prognosis is poor because of the type of lesions that we may see. Now, extension of these tumors is critical, and we need to evaluate the orbit, the infratemporal fossa, the dura, brain, retropharyngeal nodes, and perineural spread. We know that extensive brain involvement, orbital apex involvement, cavernous sinus involvement, and pterygopalatine are inoperable and possibly palliative. When we looked at the orbit, this is the anterior orbital involvement. We also need to know the posterior orbital involvement. We want to know whether it is coming onto the cavernous sinus, whether it's coming onto the carotid. We want to know about the pterygopalatine. We want to look at the greater wing of sphenoid, look for erosion, look for extension into the infratemporal fossa. I already spoke to you about the dural involvement. Intracranial extension, an extensive intracranial extension is inoperable because the survival drops down by almost 50%. So at the end of your clinical examination, you need to know what is the epicenter of the disease and what is the extent of spread. Your examination is not complete without nasal examination, wherein you want to know what the structures involved are, face and oral examination, sensation and swelling of the skin, the lip, and the teeth, which of the bone and teeth are involved, and whether there's adequate mouth opening or not. Ophthalmic evaluation includes vision and movements, as was elaborated by Shamit. And the cranial nerve examinations 1, 3, 4, 5, 6, and 7 complete your evaluation of the paranasal sinus tumors. So at the end of your examination and radiology, you should know what is the histology, the tumor spread, orbit involvement, cranial nerve status, the performance status, and the prosthetic or dental workup. With this minimum information, you can plan your treatment for your patient. Staging is very critical, and AJCC staging classifies T1 as antral mucosa with no bone erosion, T2 is bone erosion or destruction extending into hard palate or the middle nasal meatus, and no involvement of the posterior wall of the maxillary sinus or pterygoid plates. T3 is the posterior maxillary sinus wall erosion, subcutaneous tissue, floor or the medial wall of the orbit, pterygoid fossa, and the ethmoid sinus. And T4 is the one that extends onto the anterior orbital contents, the skin of the nose or cheek, minimum anterior cranial fossa, the pterygoid plates, ITF, cribriform plates, sphenoid, or frontal sinus. And the one that is very extensive, involving the orbital apex, the dura and brain, middle cranial fossa, cranial nerves other than V2 become T4B, flavus and nasopharynx. So these are the general guidelines. Usually stage 1 and 2, a single modality works, surgery or radiotherapy. In stages 3 and 4A, a combined modality, surgery with chemo, with or without chemo radiation. And stage 4B, when the performance status is 0 and 1, you can do either concurrent chemoradiation or even surgery in favorable histologies such as adenoid cystic carcinoma, low-grade adenocarcinoma. And when the performance status is more than 2, it is usually either palliative RT or best supportive care. Generally, we understand that in early stage tumors, the surgery scores over only radiation, and there are historic data that suggests that surgery and surgery followed by radiation do far better. So for your T1, T2 cancers in maxillary sinus, the general treatment options are the infrastructure maxillectomy, that is the orbit floor sparing maxillectomy with or without radiation. And you can approach them via midfacial deglowing, lateral ionotomy, or an endoscopic transnasal access in suitable cases. In inoperable or the patient doesn't offer or refuses surgery, you can offer radiation. In T3 and T4A tumors, the options are a maxillectomy or a craniofacial resection depending on its extent with post-operative radiation or chemoradiation. The patients can offer concomitant chemoradiotherapy in patients with good performance status, especially for radio and chemosensitive lesions like SNUC, small cell neuroendocrine tumors, and high-grade esthesionoblastomas. Radiation alone or neoadjuvant chemotherapy followed by chemoradiotherapy in the patients who are chemosensitive. So generally, when you look at lesions which are coming on to the medial infraorbital nerve, you can do a medial maxillectomy. For structures that are inferior to the infraorbital nerve, you can do what we call as the infrastructure maxillectomy. For lesions that involve both the compartments, you need to do a total maxillectomy. And the ones that have an intracranial spread, you combine it with a craniofacial resection. So this is how an infrastructure maxillectomy would look traditionally and would get a good obturator and a prosthetic rehabilitation. Patients undergoing a total maxillectomy will require more. As Shamil said, our focus on should be on the goals of reconstruction. So wherein you have a lesion which is effaced the orbital floor, you will want to do an orbit preserving total maxillectomy. And then you might want to do a reconstruction either with a temporalis sling to support the orbit along with skin graft and an obturator or a free flap. Now, when the orbit is involved, you want to know whether you want to excentrate the orbit or not. So we know that with the orbit involved, you should preserve only when the periorbita is not transgressed. So if you have lesions which have crossed the periorbita, that is the intracoronal compartment is involved, it would be better to resect the excentrate the orbit. So look at the apex. If the apex is involved, there's a reduction in survival and maybe inoperable. The anterior orbit is involved, you need to look at whether there's a gross intracoronal spread, do an orbital clearance. Suspicion for periorbital involvement, you have frozen section facilities, go for the involvement of the fat. And if you have the free periorbita, you should do an orbital preservation. Now, when you do a radical maxillectomy, when you have an intracranial extension, you need to combine your facial resection along with the cranial approach. We need to understand that the intracranial extension, the survival drops by 50% when the dura and brain is involved. When extensive brain involvement, consider concomitant chemoradiation or radiation alone. When there is minimum brain involvement, you can excise the involved brain if it is in a non-eloquent area, followed by concomitant chemoradiation. When the dura is involved, of course, the dura can be resected widely. However, as we go posterior onto your planum, the dura is less resectable because a reconstruction becomes a challenge. When the dura is close or not involved, you may opt for a subcranial resection. And today you might do this endoscopically or subcranially. You need not have to do a bicoronal flap. So this is the traditional craniofacial resection and reconstruction. along with the pericranial flap. There are certain caveats during surgery. Prevent the postoperative epiphora, identify the lacrimal sac and opening, and if required, do a stenting. You need to clear the ethmoid air cells because you have the drainage patterns which go through involve the ethmoid cells. And remember, wherever there is an effacement of the maxillary sinus, middle meatus, it is incumbent on us to clear the sinuses for two reasons. One is for complete clearance of disease, and second is to open the sinuses in order to prevent postoperative mucoceles. They also are terribly disturbed during radiation, and you need to open these passages so that your patients have a smooth postoperative and post-radiation course. Orbital support is very critical. You might do an orbital sling if orbital floor is excised to prevent postoperative diplopia. You might use a facial sling, which is preferred over muscle, which atrophies and causes a drag. So always consider a facial sling. And of course, you have a free tissue transfer, you'll give an adequate support. As Dr. Mani showed us today, you can use these reconstruct the orbital floors along with mesh in order to give good support inferiorly and laterally. When there's a resection of more than one orbital wall, you will need to do a reconstruction. Dr. Shamit was alluding to this reconstruction classification by James Brown, and I would urge all the residents to go through this because it is based not only on the suprastructure resection but as well as the palate. And as we go from the center to crossing midline, the need for bone reconstruction increases. So remember that as we go higher and as we cross midline, you would want to consider soft tissue reconstruction and bone reconstruction to achieve all the things that we discussed today for achieving a good quality of life. So the palatal defect less than 1/3 an obturator is recommended or is okay. And if there's extensive skin soft tissue involvement, more than half the palate, orbital clearance and skull base reconstruction, you should consider microvascular free flap reconstruction. The caveats in craniofacial is to have a good cranionasal separation. Conventional coronal approach will allow us to use a vascularized peritoneal flap. In the endonasal approach, you might want to use the nasal septal flaps, and in a craniofacial resection with orbital clearance and bone resections, you should consider an anterolateral thigh flap, which or an rectus abdominis flap, which adequately fills this defect. So microvascular free tissue transfer is for an extensive skin and soft tissue defect when they crosses the palate, when there is an orbital exentration, and when do you need to do a skull base reconstruction. Contraindications for surgery is a P4B disease, extensive brain invasion, cavernous sinus, internal carotid artery involvement, bilateral orbital involvement. Relative contraindications are extensive skin, ITF, and pterygopalatine fossa. It depends on the histology and your ability to reconstruct with a good plastic surgical team. Now, when you have a T4B and your surgery is debatable, you might consider concomitant chemoradiation and radiation alone. Now, adjuvant radiation is an option for all high-grade tumors, T2 to T4 tumors, closed margin or transection of tumor during surgery, recurrent disease, documented lymph node metastasis, bone or connective tissue involvement. 3D conformal radiation was what we were aiming for in the past decade, two decades ago. But today the standard of care is in IMRT. It has high precision. It improves dose conformity to the target. It increases the dose to define target volume. It reduces the dose to limiting organ at risk. It preserves organ function and preserves quality of life. This is the way to go, and IMRT should be considered for all your paranasal sinus tumors. Now, coming to the regional treatment, when we look at again these large data sets, we realize that more than 91% of these patients are node negative. ethmoids less so, maxilla even less than 10%. So we understand that we may want to reconsider whether we want to address the neck or not surgically or elective radiation. We know that the neck failure rate is 3% and elective ipsilateral neck radiation is preferred over elective neck dissection. The neck failure and the distant metastasis is extremely low. Now, there is a meta-analysis which was conducted and there is a paper that looked at the elective neck dissection, whether it is required, and there is no strong recommendation. Even this paper, which looked at 927 patients with maxillary tumors, they have suggested that elective neck dissection is to be suggested in T3, T4, or if the neck is to be entered for planned microvascular anastomosis. This meta-analysis looked at the patients who have received elective neck irradiation, and then they found that there was a significantly reduced recurrence rate. And when they had 4 retrospective studies and only 129 patients, so that may be something we need to relook at. But when we look at the patients who are having high-grade tumors and having T3, T4 tumors, all radiation oncologists are more than willing to do elective neck irradiation. Now, definitive radiotherapy following in the patients who are not operable, you need to go to 66 to 70 grays over 7 weeks. The important prognostic factors, however, are the histology, the T4B status, brain invasion, and ITF. Just a brief look at the RADPLAT application in paranasal sinus tumors. Group from Japan, led by Dr. Homa, looked at super selective intraarterial cystatin infusion. They gave 100 milligrams weekly over 7 weeks in all the feeders except the ophthalmic, and the indications for unresectable T4Bs and patients refusing for surgery, and the contraindication is ophthalmic artery involvement. When they looked at their survival at 6.4 years, their 5-year local progression-free survival was 65.8% in all comers, and the T4Bs had a 57% 5-year survival, which is amazing. They had no mortality, no cerebrovascular accidents, and amongst the late adverse reactions, there were 5 ORNs and 1 brain necrosis. So that actually tells us that we need to look at our patients who are in unresectable more critically, and the ones that have good performance status should be opted for high dose chemoradiation. They looked back at the patients and when they saw the ones that had a median follow-up after recurrence of 5 years, they found that the salvage surgery might be required in certain number of patients where they failed posteriorly. So the posterolateral wall and in the pterygopalatine ITF region is where they seem to fail. And in those patients, when they do a salvage surgery, the 5-year overall survival rate is 68%. So all in all, there seems to be more room for critically evaluating these patients and following them up thoroughly. I already spoke about the adjuvant radiation, and we need to give adjuvant radiation in T3, T4 tumors when there's involvement of adjacent structures like bone, dura, and brain, when there are positive margins, and when there's presence of lymphovascular invasion, perineal invasion, and positive lymph nodes. Now, coming to the outcomes, this is the paper that looked at 5 decades of treatment in sinonasal tumors, and the 5-year survival rate was 63% and the local control rate of 57%. What is striking is that the adenocarcinomas will do exceedingly well. The T1, T2s will do well. The maxillary sinus tumors don't do as well as the nasal cavity tumors, but surgery and surgery followed by radiation is your standard of care for treating these tumors. Factors associated with worse prognosis are extension to the fossa, frontal and sphenoid sinus, erosion of the cribriform plate, and invasion of the dura. And there has been an improved survival in the past 40 years. The collaborative study internationally done for craniofacial dissections looked at paranasal sinus tumors, and They found that 57% of their tumors were subcranial, majority 70% were non-squamous histologies, and the overall survival rate was 48%. It does brings us into focus that margin positivity remains high, complications are about 33%, and there is some mortality involved. So I would like to leave you with some take-home messages. Do a careful clinical examination. It is paramount. CT and MRI are essential and complementary. Biopsy with the immunohistochemistry is a bare minimum today in order to get a proper diagnosis and prognosticate your patient. Multidisciplinary management is essential. Microvascular reconstruction and prosthetic rehab is a key to a better quality of life. And adjuvant radiation to the neck in high-grade and high-stage tumors will give you better control rates. Thank you very much once again for the patient listening.
Thanks for a very comprehensive talk, in spite of not fully recovered out of your recent infection. Thank you, Prathamesh, for accepting to give a talk. Over to you, Srijan.
Yeah. Thank you, Professor Pai. This brings us to thank you, Dr. Pai. This brings us to the conclusion of today's webinar. I invite our advisor, Dr. Rajaraman, to kindly give his vote of thanks.
Thank you very much, sir. These maxillary tumors, even though they are not very common in clinical practice, whenever there is a case, it will always be kept as a short case in the examination. And it is a nice thing that the best of the business in the head and neck area has been selected for being the examiners and for the expert talk. I'd like to thank Dr. Pai for his excellent speech. It was very crisp, to the point, and made things very easily understandable to the students as well as for the other listeners. And then the next thank goes to the examiners, Dr. Shami Chopra and Dr. C.S. Mani, who made the students feel very comfortable, guided them in their own way during their presentation, and also evaluating them at the end of their examination. And special thanks to Dr. C.S. Mani for bringing us a good set of cases for presentation. And then the next thanks should go to the examinees, Dr. Ramasubba Reddy and Dr. Gayatri, who come forward to be the examiner in a All India forum. And I'm sure they would have found it very useful for preparation for the final examination. And all these videos are available in the YouTube, and it is a great effort by the IASO for keeping it as a nutshell in the video at YouTube, which can always be recollected during the examination for the students. And then my next thanks goes to my friend Dr. Narendra for the statistical segment, RR versus odds ratio. When you want to present a dry topic to the clinicians, there are two things. One is you must captivate the audience, and next thing is to make them understand the topic in a simple way. And Dr. Narendra has been successful in both, and I thank him especially for that. Then lastly, without the students and attendees, this topic of giving the lectures will not be successful. And I thank all the students and attenders who made it a success. And I especially thank Dr. Toprani, who is the president of the IASO, and Dr. Chandramohan for giving me an opportunity to give the vote of thanks. And last but not the least is the boss of the Academic Council, Dr. Subramanieswar Rao, who has always been very helpful in finding out the best in the business for over the year to find out who can be the expert talker and who can be the examiners. He was very, very helpful in finding us and helping us in choosing the examiners and the persons for giving the talk. And he was ably assisted by Dr. Sijan Shukla, who was also helpful in coordinating with all the examiners as well as the students in both technical as well as the academic aspects. And I must personally thank our past president, Dr. Arnav Gupta, and Secretary Dr. Sharad Desai for giving us this wonderful opportunity of being an Academic Council member for choosing the candidates as well as the examiners. They have always been helpful. If one of us is not able to present during the topic, then they were very helpful in charting out the problems and helping us. And then I personally thanked our co-academic council members, Dr. Sarangi, Dr. Arun Chaturvedi, and Dr. Kiran Kothari for all the cooperation they made with me and the others in the academic council for making it a grand success. And I welcome the new members to the academic council, and I'm sure they will make it a great success and carry it to the next level. Thank you very much, all. Good night.
Thank you. Good
Thank
night.
you, Dr. Rajaraman. The final announcement is about the next meeting, which will be on appendiceal tumors, and the meeting will be on 24th February, Thursday at 7 p.m. We thank everyone for their kind attention and wish everyone a good night. Thank you so much.
Thank you, sir.
Good night.
Thank you, sir.
Thank you.